orthopedic surgeon here at OrthoVirginia. We're coming to you live on our office in Virginia Beach. These specialists here in the office taking care of various orthopedic problems. My specialty is problems with the hip and knee, and specifically hip and knee replacement. I'm here to talk to you about rapid recovery after hip and knee replacement. I performed thousands of hip and knee replacements throughout the course of my career over the past 15 years, and I've learned a lot. I've learned what works well for my patients, and I've also learned something that might have success rate. And what I've come up with is this new program for rapid recovery after hip and knee replacement that I want to share with you today. Before I get started, I want to talk a little bit about my practice, OrthoVirginia. We're the largest private practice orthopedic group in the state of Virginia. We have over 100 physicians to help take care of any Virginian problems with orthopedics. We have offices in Richmond, Lambert, Northern Virginia, and right here in Virginia Beach. Virginia Beach office is located right across the street from Virginia Beach General Hospital. We're located on Willow Wick Way, and we are open Monday through Saturday, and we can take walk-ins on a daily basis. Before we go any further, if you like what you're hearing and you'd like to share this with anyone, just click the share button on the Facebook page. Now let's get started with the topic. What is rapid recovery after hip and knee replacement? Well, there's three stages of rapid recovery. The first stage is before surgery. This involves education with the patient and learning the process of recovery after surgery. So all of our patients go to a class to learn about hip replacement and knee replacement and recovery. In addition, we try to find a coach for our patients. It might be a spouse, a sibling, a neighbor, or a friend that can help after the surgery when the patient is at home. Basically, I want all of my patients to get home as quickly as possible after their surgery. Some people, that's the same day. Some people requires a night stay in the hospital. But the less time in the hospital, the better in normal times. Particularly during COVID-19, we want our patients out of the hospital as soon as possible. So preoperatively, the education piece is very important. We give each patient preoperative exercises to perform before the surgery to help strengthen the muscles around the knee and the hip prior to having the replacement. This helps tremendously in the recovery. In addition, it shows the patients prior to having surgery what exercises they will be doing after surgery. In addition to that, we have our patients screened by their medical doctor to make sure their heart and lungs are in good shape for the surgery, if they're on blood thinners, whether this needs to be stopped ahead of time. And we coordinate with your primary care doctor. Finally, we have a program to avoid infection in which we have a special soap we use on our patients before surgery and the morning of to prevent infections in our total hip and total knee population. So that's what we do before surgery. The second phase is during the surgery. And during the surgery, there's a lot of tricks of the trade that we surgeons love to talk about that make our patients get better quicker. I'm going to talk to you about some of those right now. We're going to talk about both the knee and the hip. So I have a model of a knee replacement here. When we say a knee replacement, what we're really talking about is resurfacing the end of the bone. It's not a centimeter of bone that is cut off and replaced with metal and plastic like you see here. The way we get into the knee is where things are different. So for my patients on a knee replacement, I don't use a tourniquet. I used a tourniquet for about 8 years after knee replacement when I first started, and it's certainly easier for me, the surgeon. I can see a lot better. There's not as much bleeding, and the surgery goes a little quicker. But what I found was it wasn't as good for the patient. The patient had a lot of bruising afterwards, and their muscles were very sore from having a tourniquet inflated for over an hour, and that impaired their recovery. So I stopped using a tourniquet in 2012. I have a couple of techniques that I use to decrease the bleeding, and my patients have been very happy since I started doing that. In addition to no tourniquet, we have our anesthesia team inject the knee with a block before the surgery. It helps keep the knee pain-free or close to pain-free for up to 24 hours after surgery. In addition, in a similar vein, during the surgery while the patient is asleep on the table, I inject numbing medicine as well as an anti-inflammatory medicine all around the back of the knee and the side of the knee that lasts for up to 12 hours after surgery. And this is also very helpful in helping the patients recover. Now, on the knee side, one of the neat things I do here at Virginia Beach General Hospital is I use a robot. It's called the Mako, M-A-K-O. And this Mako robot allows me to make more precise cuts, and I don't have to cut as much soft tissue in order to get in there because of the assistance of the robot. All of these things have been very helpful during the surgery to help my patients recover quicker. Now, in the operating room on the hip side, we also do some other things that are particular to the hip. So I have another model over here, which is the model of a hip replacement. So this clear stuff simulates the bone. And in a hip replacement, we replace two sides of the joint. It's a ball and socket joint. This is the pelvis. This is a titanium and plastic implant that we put in the pelvis. It's the new socket. It fits in like this, okay? On the femoral side, we have a titanium implant that wedges into the femur with a special coating called hydroxyapatite. And it wedges in to fit like this with a ceramic ball. These two go together to make the hip replacement, okay? So some special things that I do on the hip replacement is I do the anterior approach, where the scar is in the front. We don't cut any muscles. That is less pain afterward. We just separate the muscles to get into the hip joint. In addition, I have a special carbon fiber table called the HANA table that allows me and my team to position the leg in certain positions to perform the hip replacement. This allows for a quicker recovery and less pain after surgery. I also use the same injections around the hip joint that I do on the knee to help prevent pain afterwards. We have a computerized system that allows me to measure the leg length for my patients during hip replacement. Most people don't realize we actually change the length of the leg when we replace a hip. We don't want our patients to have leg lengths that are one side long and one side short, so we use a computer navigation system to equalize the leg lengths. So those are the tricks that I use in the operating room for both hip and knee replacement. The last thing we do is after surgery. Now this is very important. After surgery, there's many different forms of pain control that we do. The first one is ice. There's many different types of ice packs. The typical bag of frozen peas works wonderfully. It gets warm after about 10 minutes. So we have, for our patients, a special ice wrap with a hose connected to it that we can connect to the hip or the knee. It's connected to a cooler. And the cooler has a cord on it, like this. That circulates continuous ice-cold water to the hip or the knee to help with pain control after the surgery. In addition to that, we like to use non-narcotic pain medications. Tylenol around the clock in higher doses is very effective at relieving post-surgical pain. In addition to that, we use anti-inflammatory medications which help with the muscular pain of the surgery. We also do use some narcotics, but in a very limited fashion after the surgery. My goal is to get all of my patients off of the narcotic medication in 2 weeks after the surgery. And that's an ambitious goal in some. I've had patients take no narcotics after surgery. There's a wide range. After your surgical replacement, you will have a physical therapy consult in the hospital, and you will be reminded of the exercises that you learned before surgery. These exercises are taken with you at home, and you do them on your own every hour while you're awake. They're very simple. These exercises are posted on our OrthoVirginia website, specifically under my profile, and they're very basic. By having our patients do exercises on their own at home for the first 2 weeks, we avoid causing more pain with the therapist. Physical therapists are terrific. They want the best for our patients. Sometimes they get a little overzealous. So for the first 2 weeks, I like my patients to do exercises on their own and to wean off of the pain medication. Then when they come back for the first appointment 2 weeks after surgery, I'll examine them, make sure they're doing well, and then we will get them plugged in with physical therapy when their mind is clear off of narcotics. I think this is the best way to help with a rapid recovery after a hip and knee replacement. It's been very successful thus far. So that's a summary of my rapid recovery after hip and knee replacement. We're going to be taking some questions. If you have them, just go ahead and type them in.
Thanks, Dr. Lambert. We've got some great questions coming in, and in addition to those that were provided in advance, I'm also going to try to insert giving you questions that have just appeared. So we'll try to do a mix of that, and please forgive me if I do not attend to every question received. Someone asks, do all surgeons use your program? Do all OrthoVirginia surgeons use your program?
Well, the question is, does everyone in OrthoVirginia use my program? The answer is no. We're a strange bunch. Surgeons, everybody has their own recipe. There are several surgeons in the United States that do use this, but not all the surgeons, even here in Virginia Beach, practice use it, and certainly not OrthoVirginia-wide. This is unique to what I do.
Okay. Here is a question regarding post-surgical after effects. Why would swelling occur all the way down to the ankle?
Great question. When you have a hip or a knee replacement, gravity comes into play. So as I'm sitting in this chair, my knee is below my heart, my hip is below my heart, and my foot's even lower. I'm a tall guy. It's way down there. Blood flows downhill. After the surgery, we don't have a pump to get the blood back uphill, so we have to use gravity. So elevating the leg is crucial to get the blood back to the heart and to return the system to normal. Even in a person who elevates exactly as they're told, there will be swelling all the way down the leg and ankle. And this is where the patient education comes in. So as we're talking about now, if the patient knows it ahead of time, it's not a big deal. If we didn't teach you this ahead of time, then you're surprised, and that can be a little stressful. The swelling in the ankle and foot is normal after surgery, and elevation is usually the key.
Okay, from Karen. Are you familiar with the Jiffy knee procedure? Tell us your experience with that.
I am familiar with the Jiffy knee procedure. I believe that's a trademark term. From what I've gathered from the website, it's a subvastus approach. So there are several ways to get into the knee to do the knee replacement. I've got a model here that I think I can show you on. So with the medial parapatellar arthrotomy, which is the treatment that I do, and I'll explain why in a minute, the quad tendon is dissected around and is pushed to the side, and the surgery is performed. In the subvastus approach, which I believe is being marketed as the Jiffy knee, the entire muscle sleeve is lifted off as one unit and pushed to the side. Now, I've done it both ways. I've done a subvastus approach. I've done a medial parapatellar approach, which I currently do. I've done an approach where you cut into the muscle, called the midvastus approach. And I've also done the quad sparing approach. I've done them all. And for me, I've found the medial parapatellar arthrotomy works the best. I want to talk a little bit more about that. So as a specialist in hip and knee replacement, I get to take care of a lot of hip and knees, but I also get to see other people's work. So people who had a knee replacement elsewhere and they're having problems are sometimes referred to me, and I evaluate them. I have seen some problems with the subvastus approach, specifically a lot of hematomas and swelling and some problems with the muscle where the dissection is done on the medial side of the knee. Not every approach is perfect, but for me, the medial parapatellar arthrotomy I found best in my patients after having tried them all.
Thanks. Many questions are coming in of people who are in a recovery phase from a total knee replacement, and they are asking questions about clicking, swelling, recurrence of pain or presence of pain. And some are asking what percentage of total knee replacements are successful? So
on regards to knee replacements, the literature shows about 85 to 90% of knee replacements are successful. And that's great. That's a B plus or an A in most classes. But that's a lot of people, that 10 to 15% that are not happy. So knee replacements certainly are not perfect. I think in the early recovery, it's too early to say if it's going to be successful or not. Specifically, the question about clicking. So when you have a knee replacement, the cartilage and the bone are replaced with metal and plastic. Cartilage and bone can click and creak, but not like that's metal and plastic. And you can hear that in your knee after it's been replaced. In my experience, it doesn't happen immediately after because there's a lot of fluid in the knee and you can't hear it. As the fluid comes out of the knee, you usually hear it a little more often. And then as the muscles around the knee get stronger, there's a lot less clicking as time goes on up to a year. But there may be some clicking always in the knee. There is a lot of swelling after surgery, and everybody's different. As I said, from the knee, a tourniquet does make a difference. So patients who have had a tourniquet for their knee replacement, in my experience, have had more swelling afterwards. Elevation is usually the key to help prevent the swelling or to reduce the swelling after a knee replacement. Hip replacement, the swelling can go all the way down the leg, but we have a little more tissue around the hip, and it's easier absorbed there.
is it possible that ice would need to be used to reduce swelling even 3, 6, or 9 months after surgery?
In general, as orthopedists, when you have swelling in a joint, whether it's replaced or your native joint, ice is the answer. It could be the day of surgery. It could be a year later. When there's a lot of swelling, ice usually helps bring it down. Sometimes if you have a lot of swelling in your knee and it's been up to a year after your surgery, you might have another problem, so it might be worth talking to your surgeon or coming in for an evaluation.
What's the life expectancy for a total knee replacement?
So knee replacements, the life expectancy is 15 to 20 years. The implants we are using today are a lot better than the older ones. There's certain things that will cause the knee to wear out earlier. Number one, patient weight. The lighter you are, the longer it's going to last. Number two, the number of cycles you put on your knee. My patients, I want them to put a lot of cycles on it. Knowing that might wear it out a little quicker, I don't want them to wear it out, but I want them to enjoy the knee. So I would not worry about limiting activity. Focus more on the weight. And the last thing is that women's knees tend to last longer than men's. So men wear out their knees a little earlier. There's not much we can do about that, but the weight control is the main thing. And we hope to get 15 to 20 years out of a knee replacement these days.
Several viewers are asking, are your techniques used by other OrthoVirginia surgeons? And I want to point out to them that they may find the answers in prior Facebook Live videos, which are archived. In addition, there is plenty of contact information to reach your local OrthoVirginia practice, wherever you are in the Commonwealth, and it can be asked of a clinical coordinator or of a physician whether or not they use that technique. I know that many OrthoVirginia physicians use robotics, including the Mako, for best outcomes, but not every one and not in every case. But I just want to alert you to that. There is a question for Dr. Lambert. Are these same techniques for rapid recovery from total hip or total knee used with younger patients, athletes,
So I do use rapid recovery in all my patients and its relatives. So in my younger patients who are otherwise healthy, they don't have a bad heart, they don't have a bad lungs, they don't have kidney failure, they're able-bodied otherwise, except for the one joint that I'm fixing. I try to get them home the same day. I want to get them back to their normal environment. We try to get them off the narcotic pain meds as quick as possible. So the concept is the same, but the scale might be a little different in the younger patients. But I do hope for the same rapid recovery compared to the older methods.
There are questions about special tools and equipment used for anterior hip replacement and for an explanation of the HANA table that is used?
So the Hannah table is a pretty neat piece of equipment. We have two of them over here at Virginia Beach General where I work. It's a carbon fiber table with spar arms that move during the surgery. And there are a lot of videos online you can look at. We basically attach you to the table during the surgery. It allows me to move the leg around during the surgery, and it, I think, is a little easier access to the hip for an anterior hip replacement. There are surgeons that do it without this special table, but in my hands, I think the table works very well. I've done it on several different types of tables, and the current one we're using, the Hannah table, is the one I think is the best for hip replacement in the anterior approach.
A shout out to Cindy who asks, what if I have heart issues? How does that affect my surgery?
So if you have heart issues, which a lot of my patients do, the heart is much more important than your hip or your knee, obviously. And we work with your primary care provider and your cardiologist. So any patient of mine that is going to have surgery has to be signed off by their internal medicine doctor that this is safe. If it's not safe, we're not going to press forward. And the cardiologist and the primary care doctor help assess exactly what the risk is before the surgery, and that way we can have a discussion if this is worth the risk.
If one knee is replaced, how long until the second knee can be addressed if it also needs total knee replacement?
So there's a lot of options for people who have two bad knees. Normally I like to do them one at a time, separated by 3 months so they're completely healed. Sometimes in special situations I have done knee replacements two at the same time in very special situations in patients who are very healthy. But in general, I like to wait at least 3 months in between knee replacements on the same patient.
Now, here is a question about a total knee replacement. After 2 years, 2 years after the second total hip replacement, there is still numbness and a stabbing, burning pain. Now, what can that indicate, and what's the conversation with the surgeon at that point?
So if you're having a problem, whether it's a hip replacement or a knee replacement, I would ask you to talk to your surgeon. If I'm your surgeon, come on in. If you had surgery elsewhere, I'd be happy to evaluate it as well. But basically, you need to have your doctor talk to you about the symptoms. Where is it burning? When is it burning? And he or she can examine you and try to maybe take some x-rays and try to come up with a cause of the problem you're having, and then embark on a treatment course to make it better. But there are a lot of patients out there that have pain after a joint replacement, and evaluating it by a qualified physician is the best option.
Someone is asking about dual mobility technique. Is that something you can express and explain?
Yes, so in a hip replacement, normal hip replacement, we have a ball and socket, like this, okay? One ball, one socket. In certain situations where a patient is at higher risk for the ball popping out of the socket after surgery, we call that a dislocation. There is some technology today that is called dual mobility. So it's a ball within a ball, and it prevents the hip from popping out. And I do use that in certain situations when the patient's at high risk for dislocation. I do not feel it should be done in every patient, but the high-risk patients, it is a nice piece of technology that we have available that we didn't have 10 years ago.
Here's a question related to several viewers are asking, how do I choose my surgeon? What do I look for? What are the certifications or the experiences I need to know about?
This is a great question. As an orthopedic surgeon, I take a lot of pride in my credentials, but also as a person. I had a family member needing a knee replacement very recently, and I needed to find a good surgeon for this person. And so what did I do? First thing is we want to find somebody who's board certified. This is the American Board of Orthopedic Surgeons. This is the qualification that all orthopedic surgeons go through. It takes about 26 years education to get it. You have to take a test. A lot of people have it. It's important that you have it. When we talk about hip and knee replacement, there is a subset of surgeons who've had an additional training. This is called a fellowship. We have fellowships in different areas of orthopedics. Several of my partners have a sports medicine fellowship. They operate on athletes all the time. I don't. That's not my specialty. I did a hip and knee replacement fellowship, and because of that, that's what I specialize in. Our Hip and Knee Society, which is this one here, the American Association of Hip and Knee Surgeons, is for surgeons who are just do hip and knee replacement. It's the focus of the practice, hundreds a year, not one or two a month. And I think those two certifications are important when looking for a surgeon for your hip and knee replacement. There are a lot of surgeons that do hip and knee replacement, but the ones that specialize in this tend to be members of the American Academy of Hip and Knee Surgeons.
Fantastic. Let me grab a question that has just been asked. Are blood thinners prescribed for every patient?
So blood clots after a hip and knee replacement are a problem, and we do a lot to prevent them from happening. One of the things we do with blood thinners, but for my patients as part of rapid recovery, I like a spinal anesthetic for my patients, which numbs them from the waist down during surgery. Then they get medicine in the vein, very similar to what you get for a colonoscopy. And then after the surgery, the reason I like this is because patients wake up very quickly. And when they wake up, they can move and they can walk the same day, and they can pump their calves to get the blood flowing. All of this is to prevent blood clots. So by movement, early mobilization, we prevent blood clots. Because I'm moving my patients quicker, I don't have to use the aggressive blood thinners, the injectables, and other medicines that can cause bleeding through the new surgical incision. So for the majority of my patients, I use a simple baby aspirin twice a day after surgery. There are some situations where we have to use other medications depending on the patient's history. If they had a prior blood clot, that might change things. But because we move the patients early, we use only a baby aspirin for the majority of the patients as a blood thinner to prevent the blood clots.
Several viewers are asking if there are non-surgical alternatives to total knee replacement.
So for knee arthritis, there are a lot of alternatives. I saw about 15 patients this morning with knee arthritis, and only one of them needed a knee replacement. So the majority of our patients do not need surgery. It doesn't mean we don't want to see and treat, though. We like treating patients in general. So there are several forms of treatment. There are simple things the patient can do. Weight loss is number one. We can give you a nice talk on that, and we can help you find resources for weight loss. Number two, physical therapy. Both exercises on your own and going to see a formal physical therapist can help relieve arthritic pain in the knee. In addition, there are many types of injections that can be given. A simple cortisone shot, we give those all the time. There's a substance called hyaluronic acid. These are the lubricants or gels that can be injected in the knee. We do those here in our office. And there's some newer exciting things such as platelet-rich plasma and stem cells, which are newer treatments, and we can discuss more of those in a later venue. Beyond that, there's medications, a simple anti-inflammatory medication, naproxen, Advil, Aleve, Motrin, and many others. All of these things are helpful in treating knee arthritis, in addition to some braces. Surgery is always the last resort. I love talking about it. I'm a surgeon, I like to do surgery, but most of my patients don't need surgery. We treat them without surgery.
Someone is asking, in the context of total hip replacement, about PSOAS removal. Can you explain that?
So the psoas muscle is a muscle that goes across the hip joint. Sometimes after surgery on the hip, this muscle gets irritated and can be a source of pain. There are many ways to treat this particular problem: medications, physical therapy, injections, and sometimes even surgery. I've only operated on one psoas pain person after surgery of all the ones I've done, but there are many options without surgery to fix this small problem of psoas tendonitis.
Fantastic. Let's see. A runner is asking, is it reasonable to expect that I can run 2 to 3 miles daily after a total knee replacement?
Well, I don't know how you define reasonable, but I think I'm a runner myself, and if I had my knee replaced, I would absolutely try to run 2 to 3 miles a day. I'm not sure I'd be able to do it. Knees are a little tougher than hips. So people that need to run for many reasons like myself, I recommend that after they are healed from the surgery, they give it a try. Most of my patients who have a knee replacement do not run, but we have a very select few that do. I would not get in your way if you wanted to be a runner and that was important to you. I think it's worth a try, but most people who have a knee replacement do not run more than a couple hundred yards.
Is stem cell therapy still used to treat hip arthritis?
Stem cell therapy can be used to treat hip arthritis. It's not FDA approved. Insurances don't cover it. It's expensive. Does it work is the real question, and I think the jury's still out on that. There is some early data to show that it does, but I'll tell you, it's got a ways to go to prove it's a good treatment for hip arthritis.
Quick question about can I go back to downhill skiing after total knee replacement? And I guess this relates to the running question.
This one's a little easier. So I have a lot of skiers that have had their knees and hips done, and I think that's a lot easier than running. So yes, you can. Most of my downhill skiers, by the time they've gotten to the point where they're getting a joint replacement, hip or knee, they've stopped doing moguls, they're doing blue runs, and that is A-okay after a knee or a hip replacement. And it's encouraged, actually, it's good exercise.
Someone is asking about the cost of injections, but
so I don't have cost information in front of me. I will tell you that most insurances, all insurances cover a steroid injection. That's pretty standard routine. The hyaluronic acid, most insurance companies cover that for the knee. The other injections are not approved by most insurances, and those are platelet-rich plasma and stem cells. And I don't do a lot of those because I think they're pretty expensive, and I'm not sure if they're worth it for my patients. But we certainly have those capabilities here in our office. We have that ability to do all of those injections.
Everyone is now commenting, bringing forward their own sport, horseback riding, racquetball, tennis. I don't see squash, but it's on the way.
So these activities are great activities, and I will tell you that after a joint replacement, hip or knee, the main activity that is the most challenging is running, because it's a series of jumps. Most of the other sports, you are fine. Tennis, fine. Racquetball, fine. Horseback riding, fine. All of those, unlimited hiking, walking. It's just the act of running, and I do have some runners that I have replaced their hips and their knees and still do it. But for the most part, running is challenging for a hip and knee replacement patient.
And the number one question, and we've seen this several times now, is it how soon can a return to work be expected?
That's a highly variable question. How quickly can I get back to work after my surgery? Well, I think the record is 1 week, and on the other end, we've had people that have never returned. It has more to do with the patient's desire to return to work than it does to do with me as a surgeon. I will support you as much as I can. I try to get folks back to work in 6 weeks. All come. Some people go back much quicker, and some people, depending on the situation, take a little longer to get back. The number one factor in how quickly you get back to work is how badly you want to get back to work. And that's a big part of it, and the patient's desires are important for us too.
We're now at the 35-minute mark, and in order to make this very watchable, it will be archived as soon as it is completed, and many questions that were addressed early on in the video, you'll be able to catch them as you watch it. But we're going to wrap up now. I'm going to give Dr. Lambert a moment to make a closing comment or say farewell, and then we are going to wrap it up.
Well, again, I'm Ted Lambert. I'm an orthopedic surgeon here at OrthoVirginia. Thanks for joining me on this discussion of rapid recovery on total hip and knee replacement. If you have any questions about this, please come in and see me. Come to our office in Virginia Beach. We'd be happy to talk with you and see if we can get you back to an active lifestyle, which is our goal. Thank you very much for joining.